Okay. Good evening, everybody. There has been some confusion regarding the transmission and perhaps partly the system problem and partly my net problem. So we are doing this talk without the video component. I'm sure that you will hear me. Good evening, Divyesh. This is going to be a rather elementary one. See, when today one speaks of PDA, what you think immediately is about closing the PDA, the devices and the coils. There's going to be a separate session for that. But there is a lot more about PDA that we take for granted. I just want to make sure that those things that we take for granted, you know quite well. So this is going to be an interactive session. The first question is how to suspect PDA in a preterm baby. I want a response from you as to when would you suspect PDA in a preterm baby? Yes, good. Heart failure, wide pulse pressure. Okay, very good. So the lower the birth weight, the greater the chance for a PDA. If you have a baby with a weight less than 1 kg, the chances are 80%. So the birth weight itself is a predictor that there is going to be a PDA or not. So in a low birth weight baby, if you have a systolic murmur, if you have a bounding pulses, if you have cardiac failure, if that failure is bad enough to be dependent on the ventilator, these are some of the circumstances in which you would suspect a ductus in a preterm baby. Now, when would you close a PDA in a preterm baby with pharmacotherapy? When would you use indomethacin or brufen to close a ductus in a preterm baby? What's your idea about the indication? Divyesh believes that as soon as a PDA is detected, you should close it. And there's another response that clinically significant cardiac failure. There are different ways of looking at it. All of you are right, and there is obviously some confusion on the topic. So when you're actually seeing a ductus and the neonatologist is a baby with a ductus and the neonatologist is asking your opinion, do you think I should give indomethacin to this baby? If the baby is in cardiac failure, you have no problem. Definitely you need to recommend. If the baby is ventilator dependent due to cardiac failure, you have no problem. You definitely recommend. But in the absence of it, you have diagnosed a ductus by echo and the neonatologist is asking you this question. That is when the question is going to be more difficult for you. In such a setting, look for left atrial enlargement on echo. And remember, in a neonate, in a preterm neonate, a LA iota ratio more than 1.1 is significant. And in fact, the adult ratio of 1.3 would mean quite a lot of heart failure. So a ratio more than 1.1 should make you recommend it. Plus, if the neonatologist feels that he has to restrict fluid to control the baby's heart failure, you need to, the baby is actually in heart failure and you may as well close the ductus. Ventilator dependence I already said. And some people do believe that below the weight of 1 kg, if you actually have a ductus, it's better to close it. Now, which of these statements is true? You have a high chance of a ductus at a high altitude. Maternal rubella is associated with a PDA. PDA is not present in absent pulmonary valve syndrome. Sorry for the wrong spelling of syndrome. And in a right aortic arch, PDA is usually connected to the RPA. Can you take this one by one? There's a high chance of PDA at high altitude, right or wrong? Right. Okay, that's fairly straightforward. Maternal rubella is associated with PDA, right or wrong? Right. Now the next question. I want the response from all of you. PDA is not present in absent pulmonary valve syndrome. Now what does W mean, Shabak? I have no clue. PDA is not present in absent pulmonary valve syndrome, right? Divyesh believes it is right. What about others? Shraddha thought it was false. Any other response? Characteristically, in an absent pulmonary valve syndrome, the ductus is absent. You can say that there is an agenesis of the ductus in an absent pulmonary valve syndrome. Remember that. Now the last one. In a right aortic arch, PDA is usually connected to the RPA. Divyesh thinks it is right. Any other response? No, actually, in a right aortic arch, that the PDA is still connected to the left pulmonary artery. The less commonly it is connected to the RPA, and that also is one reason why a right arch with a left ductus becomes a reason for a vascular ring. Anyway, as long as you're aware of both the points, it's fine. Now, moving on to the term ductus. You have heard of this Kirchenko classification. You know what is Kirchenko classification? Anybody wants to attempt to describe it? Okay, I don't think it's fair to ask you to describe it that way. Yeah, it is based on morphology. So I've shown type A. Would you rather describe it? Good, Pankaj. There are 5 types. So I'm just taking you through the things. Look at type A. This is the conical ductus. And what does it characteristically have? There is a well-defined ampulla and there is a constriction near the PA end. And the type B ductus is a short, very wide ductus which is practically without a length. So it's a AP window-like duct. Type C is a long tubular duct without constriction. Type D has multiple constrictions, and type E is an elongated duct with a remote constriction, may have multiple constrictions also. So those are the Kirchenko classification types. Now I'm taking you through a clinical scenario. I want you to go through this carefully. Here's a 3-month-old baby girl, second child born to non-consanguineous couple, who is brought with complaints of fever and dyspnea of 3 days duration and feeding difficulty of 2 weeks duration. Just note that history. You're going to have a question now. Now, what additional information at this point will you look for in the history? You have a 3-month-old baby with fever and feeding difficulty. What additional information do you think you would like at this point? Okay, these are some of the other things that you might want to know. How much preterm was this? In this case, this was a preterm cesarean baby. Cesarean was due to pregnancy-induced hypertension. Birth weight was 2.2. It currently weighs 3.5 kg. So the baby doesn't have a terrible failure to thrive and had an uneventful neonatal period, and there's no relevant antenatal history. Okay, so there isn't much other history to go with. Now, a question, from this history, what do you think the baby is suffering from? All that you know at this point is that you have this preterm baby, now 3.5 kg, has come with fever, has feeding difficulty. So what's your clinical diagnosis? Divyesh says it's a large left to right shunt. Anything else? And yes, Divyesh wants to know whether it is syndromic. We'll come to that point. But before you think of the syndrome, the available clinical data does give you a diagnosis. What would that be, the clinical diagnosis? These are your options. Can you choose from these options? Okay, maybe the combination may confuse you. The baby, I'll just go to the next point. So the baby has evidence of lower respiratory tract infection with fever and dyspnea, and the baby has feeding difficulty and failure to thrive. So the combination does suggest heart failure. So this is a classic situation where a baby who is in heart failure due to something. Now you have no reason to say it is definitely due to electrolyte shunt at this point. Somebody responded initially by saying that it's electrolyte shunt. At this point, it can be cardiac failure due to anything. For all that you know, it may be a coarctation of aorta which has resulted in cardiac failure, and the baby has come with lower respiratory tract infection. And remember, when you actually see heart failure at 3 months of age, do take your mind through this checklist. You definitely have large electrolyte shunts leading the list, but it could as well be obstructive lesions which have gone into ventricular dysfunction, or it could be a cardiomyopathy. After all, our history was only 2 weeks. It could even be a cyanotic baby. We haven't told you the saturation of the baby. And if it is cyanotic, it is a cyanotic baby with an increased pulmonary blood flow. So at this point, we are a little broad on the cause of cardiac failure. We do know that there is a lower respiratory tract infection. And I told you in the beginning that I'm taking this as very elementary. So let me ask you this elementary question. Why do left to right shunts not become symptomatic at birth? Why is it that left to right shunts are not symptomatic at birth? Very good. So there's a high pulmonary vascular resistance. So the PA pressure and the pulmonary vascular resistance are both high at birth. It would normally regress by 4 to 6 weeks, and that's the time taken as the PVR is dropping. The left to right shunt increases, and as a corollary, a previously unappreciated murmur may become noticed at this time. So with this background, we know that here is a 3.5 kg baby. The baby has history suggestive of heart failure and an LRTI. We are going to examine this baby. These are the examination findings. The baby looks sick. The baby is irritable. It's tachypneic. Respiratory rate is 72 per minute. Retractions, tachycardia, fever, high volume pulses, and all the peripheral pulses are well felt. Okay? You're going to get a question now. No, not yet. There is no cyanosis. Saturation was 93%. There are no dysmorphic features, but there is cataract. The weight is 3.2 kg. The height is 57 centimeters, and the head circumference is 37 centimeters. The baby has a hyperdynamic precordium, some cardiomegaly. There was no left parasternal heave. The first and second heart sounds were normal. The second sound was closely split, and there was a third sound. And there was a continuous murmur, 3/6, best heard below the left clavicle and in the pulmonary area. So you got the story fully now. Respiratory system showed some crepitations. There was some hepatomegaly, an irritable baby, no focal deficit. So now you take the question, what is your clinical diagnosis? Nobody has responded. What is the clinical diagnosis? Yes, very good. It's rubella syndrome with PDA. I'm glad that you noted the combination. So we have bronchopneumonia, or let's say either pneumonia or LRTI, whatever you want to say, congestive heart failure, and you have an cyanotic congenital heart disease, left to right shunt, and a ductus arteriosus. We're going to come back to the rubella syndrome later. At this point, I'm digressing and asking you, how does a PDA develop? Developmentally, what is the ductus arteriosus formed from? Responses? Very good. It's formed from the sixth left arch. You could also say from the distal part of the sixth left arch. This is the picture to remind you of that. That marks the arches and their subsequent course. So it's the distal part of the left arch, sixth arch forms the ductus. And at this point, just reminding you of fetal circulation. What does the ductus arteriosus do? What does the ductus venosus do? And what does the foraminal do? We'll just go through that. Look at this picture. Remember, the right ventricle ejects 2/3 of the combined ventricular output. The pulmonary flow is only 6 to 8%, and the ductus therefore carries 55 to 60% for the combined ventricular output. And the ductus is diverting the flow away from the high resistance pulmonary circuit to the descending aorta and the low resistance placental circulation. So you have the large pulmonary blood flow in the fetus. Had the fetus had a large pulmonary blood flow, it would all be wasted, and the ductus arteriosus reduces the total workload of the fetal ventricles. So ductus, remember, is something which is essential for fetal circulation, but it is designed to close at birth, elementary. Now, why is the ductus remaining patent in the fetus? What keeps the ductus patent in the fetus? Responses? There are no responses. What keeps the ductus patent in the fetus? Good. At least Divesh has some idea. Remember, the ductus is facing a low PO2, and the low PO2 dilates the ductus. The prostaglandins, both E2 and I2, are produced by the placenta and also locus. They do dilate the ductus, and they remain in circulation longer because of the low flow to the lungs. It is in the pulmonary circulation that the prostaglandins are inactivated. So circulating prostaglandins are the major reasons for ductal patency in the fetus and also in the preterm baby. So how would the ductus constrict at birth? What makes the ductus constrict? The high PO2, yes, Divesh, it induces constriction via inhibiting voltage gated potassium channels. And the loss of the placental source of the prostaglandins and the easier inactivation of circulating prostaglandins in the lungs also contribute to the ductus constriction. And perhaps other vasoactive substances are also involved. So that is a ductus. You are all familiar with this view. Just to remind you that it is there. Now, do you consider other possible diagnoses in this baby? You already said rubella syndrome, but look at the differential diagnosis of a continuous murmur at this age. Can it be an aortopulmonary window? An aortopulmonary window that's large and non-restrictive is likely to produce either a systolic murmur or quite often no murmur at all. You just get evidence of a large flow or PAH. You could also have a coronary AV fistula, a systemic AV fistula, or a pulmonary AV fistula. Here the site of the murmur is helpful in establishing a diagnosis. And remember, our patient had the murmur best below the clavicle. So you don't have a problem. It is ductus. Major aortopulmonary collaterals in a pulmonary atresia, DSD situation, can also produce a high flow. and then the murmur is usually in the back. So remember, when you see a baby with a continuous murmur, even though it's very likely to be a ductus, there is a differential diagnosis possible, and try to go through this checklist and exclude those possibilities. Now, I'm also taking you through what is a classical PDA murmur. It's called the missionary murmur. It's called the train internal murmur. It's called the Gibson's murmur. So it begins after the first sound. It rises to a peak in late systole near the second sound. It runs across the second sound into the diastole, and it declines in intensity towards the latter part of diastole. These are the characteristic features of the ductus murmur. The missionary murmur is a coarse murmur of a moderately restrictive ductus. It is punctuated by eddy sounds or multiple clicks. And in this baby, can you draw a conclusion about the size of the shunt clinically? Is it a small ductus, moderate ductus, large ductus? Can I have your thoughts? You have been hearing me continuously for some time. Okay, Divyesh thinks it's a large ductus. Okay, any other response? Nobody thinks it's a small ductus anyway. Good. You could argue whether it is moderate or large. Shabda, very good. It is unlikely to be a small shunt because there are symptoms. There is cardiomegaly, and in a small ductus you usually have an incidentally detected murmur. It's unlikely to be a large shunt because they do have shorter murmurs. In an infant, it's quite often a systolic murmur, and you may be familiar with a baby which is presented at 3 months or 4 months with no murmur but with bounding pulses, cardiomegaly, and cardiac failure. So this is more likely to be a moderate shunt, and after all we have a continuous murmur. And let's also be clear as to what we mean by a small shunt, a moderate shunt, and a large shunt, and what are their consequences. So this is what a small ductus is like. You have a shunt less than 1.5. It's likely to be less than 3 mm in a bigger baby, because in a preterm baby a 3 mm would be a large ductus. PA pressures are normal, therefore the gradient that you would get across the ductus in Doppler is going to be high. Clinically, there is a characteristic continuous murmur. Any form of imaging does not show left atrial or left ventricular volume overload. Baby is likely to be asymptomatic. ECG and chest X-ray would be normal. These things tell you that the ductus is small. And if it's moderate size, you're expecting a flow ratio somewhere like 1.5:2. The ductus could be anywhere from 3 to 7 millimeters. Mind you, the size is always tricky. It is related to the baby size. The pulmonary arterial pressures are elevated to half or a third or two-thirds of the systemic pressure, but it's not systemic. It is subsystemic. Pulses are bounding. You will have a hyperdynamic precordium and a forceful apex. You have a continuous murmur. Your echo and X-ray will show an LA and LV volume overload, and it's likely to become symptomatic around the second month or third month, but very likely will become asymptomatic later on in infancy. ECG will show LVH with volume overload. Chest X-ray will show cardiomegaly with the LA enlargement, and the pulmonary arterial branches are prominent. Lung vascularity is increased, and echo will also show the features of LA-LV volume overload and pulmonary artery dilatation. These are all features of a moderate size ductus. And if it's a large ductus, you have a shunt ratio more than 2. It could be more than 7 millimeters, particularly in an older child. And the PA pressure is near systemic. Therefore, the shunt is determined by the relative ratios of pulmonary versus systemic vascular resistance. The child is likely to be grossly symptomatic with heart failure and failure to thrive. Pulses are bounding, wide pulse pressure, hyperdynamic precordium, forceful apex, maybe an RV impulse also is palpable, and you tend to have a systolic murmur. If there is a continuous murmur, you have to listen very carefully for it. More often, you have a systolic murmur or no murmur. The apical MDM, third sound, loud P2, these things are present. And ECG shows not only LVH but also RVH. And chest X-ray shows cardiomegaly and echo shows cardiomegaly, meaning that all the chambers are increased in size in echo, and the lung vascularity is very definitely increased. So the other question, any other striking clinical feature that warranted further workup? You had already answered it, but I'll ask that question once again. Apart from the ductus, what was the other thing which was impressing you in this baby? Cataract. And if you notice that head circumference of 37, the child had cataract and microcephaly, both of which would go with the rubella syndrome. And what is the classical triad in rubella syndrome? We have cataract, deafness, and congenital heart disease. And happens when mother develops rubella during the first trimester. You may not get the history because the rash may be very mild, and you definitely need an ophthal and ENT workup. Failure to thrive is very common with congenital rubella syndrome, and congenital heart disease you will find in more than 95%. Other than PDA, you can get peripheral pulmonary artery stenosis in rubella syndrome. What are the multiple clicks in PDA? I referred to earlier, but what are the multiple clicks and what does it denote? Any comments? They are the eddy currents, yes. And if you hear them, it denotes a longer PDA. The eddy currents are generated by the vibrations from the sort of bent walls of the PDA. So it denotes some length to the ductus. What is the second sound like in a PDA? What is the second sound like in a PDA? It's normally split. If said it is wide and variable split, yes, a small PDA can have a wider split. Yes, I'm getting all responses. So the width of the split will depend on how big the shunt is and whether there is heart failure. Commonly, it's a normally split second sound. In presence of PA, the split would narrow, but still would be audible. And in presence of PA, of course, the P2 would be loud. This X-ray, what is the difference between this X-ray and that of an ASD or VSD? I say that this X-ray is that of a ductus. Now, what is characteristic of a ductus in this X-ray? Can you describe this X-ray for me? I'm waiting for, yes, there is cardiomegaly. What else? There is an increased pulmonary vascularity. There is prominent main pulmonary artery. Anything else? I want you to see here. All this cannot be the main pulmonary artery. In a ductus, it is not only the main pulmonary artery, but the upper descending aorta is also dilated. The ascending arch and the upper descending aorta are dilated. What will cast a shadow on the left upper cardiac silhouette is the upper descending aorta. So this longer length to this prominence, a pulmonary artery would have been just a convexity filling the pulmonary bay. But when it's a longer length of prominence of the left upper cardiac silhouette, that is the feature of ductus. It does not happen in ASD or VSD. Remember, in an ASD or VSD, the shunt circuit does not involve the aorta, whereas in a ductus it involves the aorta all the way up to the upward descending aorta. Therefore, the upward descending aorta is dilated and it casts a shadow along with the main pulmonary artery in the left upper cardiac ciliate. Okay. What are we seeing in this picture? This photograph shows something. I hope you can actually see it. Yes, you're seeing differential clubbing. Perhaps you can also make out the differential cyanosis. I do not know how good the image as you are receiving is, but you can see that the digits are quite pink, while here the toes are quite blue. So there is definitely differential clubbing. There is differential cyanosis as well. So that's a feature of isolating a PDA. Differential cyanosis is what you saw. In that context, let me ask you, what is reversed differential cyanosis? What is reversed differential cyanosis? What is that, Divish? PGA with PDA? Something else also should be there. So in a reverse differential cyanosis, it means, yes, with coact, yes. So it's PGA, PDA, and coactation. In if the lower limbs are pink and the upper limbs are blue, that means what is perfusing the lower limbs through the ductus is a better saturation. Okay, and if the lower limbs are being perfused with a better saturation, that should mean that the ductus is able to have pure blood in that, which will mean that the pulmonary artery is arising from the left ventricle, hence PGA. And if the PDA is free to perfuse the lower limbs, the antegrade flow across the isthmus is obstructed. So there's coarctation. So it's PGA, PDA, and coarctation or interruption is the reason for reverse differential cyanosis. And remember, in Taussig-Wing anomaly, the incidence of coarctation is to the tune of 30 to 50%. So in Taussig-Wing anomaly in particular, you may see this. So now we come to management. What all things would you like to do? You would definitely see an ECG, chest X-ray, echo, and you would also like a workup for rubella syndrome. And you'll do an echo. You need the echo because you want to have a definitive diagnosis. You want to see the physiology. Is it a small ductus, a moderate ductus, or a large ductus? You look for any associated anomalies. You may not need to hurry with the echo because your baby is very sick. You can stabilize the baby and then do it. And a continuous wave Doppler will show continuous flow and it will show the gradient between the aorta and the pulmonary artery. Now here's the question from, I'm giving you the answer also. The first surgical ligation of ductus, 1938, Gross and Hubbard, a landmark in the history of cardiac surgery. So in this baby, you need to manage the bronchopneumonia with antibiotics, manage the congestive heart failure with diuretics and digoxin, and then you should think of definitive management of congenital heart disease. And we have already said if it is a preterm infant, you would do a pharmacology closure with either indomethacin or ibuprofen, and if it is unresponsive, you would offer surgical closure. You don't give prophylactic indomethacin or brufen to every preterm baby, but some people do consider it below for preterms below 1 kg. And what's your approach to infants and older children? All significant PDAs need to be closed. So the standard of care is a transcatheter closure, but if it's a very large ductus, you may opt for surgery, and in a small baby in particular. And you have the option of using a coil or multiple coils versus devices. Generally, 3 mm is considered the cutoff point for coil versus devices. you may choose a device for even a 2 millimeter if that is what you prefer. But if you're using coil more than 3 millimeter, you will need special techniques. And surgery is reserved for the PDA, which is too large for device closure. Typically, a small baby with a large ductus. Uh, uh, I will not ask you what this is. In any case, there will be a separate session on the transcatheter closure of ductus, the very next class. And these different coils and materials also, I'm just showing them to you. But this question I would ask, what is the standard recommendation for a large or moderate size PDA in cardiac failure and pulmonary hypertension? We would close by 3 to 6 months. If it's a moderate PDA where the baby is doing well, you could do it later, closer to 1 year. If the baby is absolutely all right, if you wait a little longer, there's no harm done. And if a small PDA, if you're seeing it at 12 months or 18 months, you can close it at that time itself, or maybe you do it a year later or so. I've followed the recommendations of the consensus meeting for congenital heart disease management in India. Thank you. Do you have any questions? I would like to know whether you can hear me at this point. Are you hearing me? Okay. Yeah, that picture actually shows you where I am now. Any questions?